So I must say thank you for inviting me, although to be honest, I would prefer to be in a beach and enjoy the nice weather in Pachinamos, as Nikos says. So it is an exception that I'm here on this weekend. So the talk is rather unusual. It has to do with engagement and decision shared making in patients with respiratory diseases. And before going to details about the respiratory diseases, I would like to clarify what these two terms mean. So patient engagement refers to the active participation of patients in their own health care, and it involves empowering patients to take an active role in their health and to work in partnership with their healthcare providers to achieve better health outcomes. When it is optimal is when the patient and the doctor has an active role, and the patient has an active role in own health management, participating in regular checkups and follow-ups, appointments, following a prescribed treatment plan, and adapting healthy habits. So the key benefits of patient engagement is that it improves all health outcomes. And when a patient is engaged, it's very likely that he will adhere with treatment, with management of risk factors, and etc. We will have lower rates of readmission, fewer hospital visits, and improved quality of life, while the communication will improve, and we will have a better personalized and effective care. And most importantly, we will have also patient satisfaction with the doctor and with the disease in general. The shared decision-making is a collaborative process where physicians integrate scientific evidence with patients' goals, preferences, and values to make healthcare decisions. And the scope is to enhance patient involvement and understanding. And the usual question is, okay, how are we going to do that? We will show later on how. The brand questions is a very useful tool. And the problem and the main barrier that many doctors mention is that we have time constraints, and this does not allow us a lot of time to be able to do that. And another barrier that is often mentioned is the low health literacy of the patients, which is also a reality. So there is a huge need for training for primary care, and not only for primary care physicians, in shared decision making. So this is the brand questions that can help you in the consultation. It has been developed by UK. And the B stands of discussing what are the benefits of a treatment, of a choice in risk factors management or whatever. What are the risks? You have to inform the patient and discuss about that. What are the alternatives? This is something that we miss a lot. We usually don't speak and we don't discuss about the alternatives. And what will happen if I do nothing as a patient or as a doctor? So this could drive you to the questions. The barriers are part of the ones that we mentioned, is that we know the limited duration of an appointment is a crucial problem, we would say. And we know that when we spend quality and quantity in time, then all the outcomes improve. So one size fits all, it's not what we do in medicine, and we know that. The patients may choose other options because of limited response rate or whatever financial issues, social issues, and we should take this in consideration. The decision for change, the behavioral change of the patient, is very complicated, and this is a slide that we use a lot in primary care, because we have to take in consideration the attitude towards behavior, the subjective rules, for example, the family, and also the perceptual control of behavior in order to be able to make differences. And the motivational interview could be a very useful tool. We use it a lot in primary care because we have a lot of diseases that there is a need to apply. So in order to say the basics about the motivational interview is we can remember these frames as an acronym. So to take feedback, assessment of the patient's current condition, responsibility, assignment of personal responsibility of the patient for change, advice, give a clear advice on the necessity of change, menu, providing alternative strategies, what we said before, empathy, understanding the patient's experience and needs, and supporting self-efficacy. One other thing that we should take in consideration is that we have to do a lot of educational to be able to show to our doctors how to improve their skills towards shared decision making and how to take a new role in consultations, working together with the patient to make personalized decisions. And as you can see, this has been designed as an audit, so it goes up and forward, so in order to get improvements by the results. And here you see there is a very specific step. I'm not very good with that, but anyway, the patient decision aid that we can support. Okay. We have to support also the patient with patient decision aids in order to be able to have better results of shared decision making. And you will ask yourself if shared decision making is something that the guidelines and engagements have gave a lot of importance. And as you can see here, the results are not good. So the gold report has only one reference, speaking about engagement on education and self-management. And also a shared decision making is only referenced once on the choice of inhalation device. And this is quite scaring, I will say, in 300 pages, 400, how much it is, to have only two very small references that they don't say anything in reality. Zina is better. It speaks more about engagement, about the asthma review, how we should do it, the breathing exercises, it says that the patient should be engaged. It's better also because it speaks about the therapeutic trial and the engagement and the alternative choices that will have to be discussed with the patients. It speaks very particularly on shared decision making. This is important. And it speaks also about the choosing the medication, inhaler, and devices in a shared decision-making process. I don't know how many they do that, but anyway, it speaks a lot. And it says if you want to improve adherence, then you have to apply first the shared decision-making in order to be able to have better results. And again, in the patient speaks also about the patient healthcare provider partnership, which is really important, and also the shared decision making based on patients' preferences. So I prefer Gina over Gold. And you will ask me also if there are tools to be able to do it in our consultation and to improve ourselves. Yes, there are. This is one tool, the Observer Option 5 tool, which is used to see if you are doing a good shared decision making. And this is a second one, the 9-item shared decision making questionnaire. They are all available in many languages. And this is one very important, which is a traditional decision conflict scale, when there is a conflict with the patients about their decisions and how you can motivate the patient to do a shared decision making. And this is something that in primary care we use a lot because you can give it in the waiting room, so you can see which are the expectations from the patients and move forward with that, so you get one step before. And there are many models, and this is, you can see that they are from chronic respiratory diseases, and it is based in a huge review that says what you have to do is to give patients informed decisions like experience, skills, knowledge, motivation, views, culture you should take in consideration. and also take in consideration the experience, skills, and these characteristics of the health professional, and try to compare that and do a good consultation process that you will exchange understanding, reason about preferences, and implement agreed choices. The education of physicians should come first, and you can see there are huge barriers, but these studies and the review I mentioned before says that if you manage to educate the doctors, then the results are much better for the patient. And the doctor-patient relationship and how to take the history and how to communicate with the patient is not something new. Hippocrates first spoke about that, but this is also the Calgary-Cambridge model that it has been applied for more than 2 decades now in all primary care practices, and it says exactly that, to explanation and planning, to do shared decision making, to use appropriate non-verbal behavior and building the relationship. So I hope I will be able in the next decade to see this develop in practice. And there are a lot of quality standard position statements, like we have from NICE and the UK recommendations for primary care, that it says that we should set standards, quality standards, in order to improve care. And this is what is proposed, and also the COPD care model, in order to be able to make the patient more active and use action plans that you will give them to work with in their practice. The NICE, again, the national system, says you should be welcoming, kind, positive, professional, and respectful. And always the consumer, the service user, the patient, should be in the center and have an individualized approach. So if you go to NICE, because you will ask me where can we find all these tools, there are all these tools. There are the decision aids in many different diseases and also in chronic respiratory diseases. And there are also standards framework to achieve better quality of care, as discussed before. If we do that, we know that the strength of treatment preference will increase from 80 to 100% if we use also patient decision aids and we do a consultation form as I propose. So there is value of doing all that. And there is also this framework, the decision 2, shared decision-making training program, which is online and it is self-tutorial for doctors and patients. I'm not going to give details, but it is completely free. And you can see how you could improve your skills in that. Decision aids from NICE, just to have a look. And this is more. And also how to use it as a patient. Now, IPCRG, the International Primary Care Respiratory Group, contrary to Gold and Gina, excuse me for saying that, includes the patient in the decision. So all these tools that have been developed and the desktop helpers have always the patient in the epicenter of care and include that. For example, there are COPD magazines about the patients, about how they should eat, the diet, the sex. Nobody discuss about sex in Gold or NICE or Gina. The only magazine that has instructions is the COPD magazine of primary care, and how also to communicate with the patient and see what can be done to be improved. And there are all these question and challenge cards, which are short discussions with the patients. So if a patient has a question, what you should answer in order to be able to improve communication. That's the objective. And all these tools are translated in more than 40 languages. So they are easily done in every country. And I am finishing in a few moments. You see, there are plenty. And this is, for example, is the COPD wheel, where you sit with the patient and you discuss all the problems. So, for example, vaccinations, the smoking cessation, the PR, the risk factors. So it drives you to the consultation process of a shared decision making and what to do. And the mental health, for example, the breathing, thinking, functioning model is discussed, especially with the patient. And also, just as a last or pre-last, I'm not sure, slide, this is how to deal with the low literacy patients and low literacy in general. So there are rabbits with different expressions in order to be able to reach also patients that they don't have good literacy and not at all health literacy. And this is also for the asthma. And in conclusion, shared decision making is very important as a patient-centered care. The physicians can provide personalized, effective care and shared decision making if they are trained. Unfortunately, they are not. And this leads to better health outcomes. Thank you.